Nothing that I say or that's in the PowerPoint presentation should be taken as a substitution for getting real legal advice on this, because this is really, it is a very difficult and complex subject. The laws on drug testing and some of the things we talk about are different from state to state, and they change from month to month, so it's very complex. So as you look at your drug-free workplace policy, it really should be reviewed by somebody that has, you know, some legal background and knows what they're doing about it. But we'll give you some basics as we talk about this. So we've already talked about those. So the opioid medications are the main thing we're going to be addressing. And these are some of the pills that we're commonly talking about. We're talking about morphine, we're talking about oxycodone, hydrocodone is the Vicodin or Zohydro, methadone sometimes. There's others, there's Dilaudid, there's fentanyl is really making a big comeback nowadays. It actually, I didn't have it on there, but obviously includes heroin. Heroin is an opioid medication. Heroin, even though it's illegal in this country, is legal in many other countries. They use it for pain relief in England and many European countries. In the United States, we just felt it was so addicting it wasn't worth it, so we made it illegal. But it is a good pain reliever, and it's just like all these other medications. In Wisconsin, I've heard that you're seeing a lot more heroin. We're seeing it nationwide, and that is very definitely the trend. As people start on the pills, and as they increase their dose, they end up changing to heroin. You know, again, I'm doing treatment. I'm seeing people every week and admitting them to my treatment program and hearing their stories. And almost all of them that are on heroin, that's their story. They started on Vicodin or Percocet. As time went on, they had to increase the dose to get the same effect. And finally, it gets to where they're spending $100 or $200 a day on their habit. And they find that a change to heroin, they can get the same effect for $40 a day. So it's an economic thing. They change to heroin because they can afford that and because they can, you know, continue their habit when they're running out of money. So heroin obviously has a lot of problems of its own, and we're seeing a lot of overdoses now with that. So when we're talking about the prescription pain medications, we're not talking about the NSAID medications, the non-steroidal anti-inflammatories. Those are the ibuprofen, Celebrex, naproxen, Aleve, some of those medications. Those are prescription. Some of them are prescription, some are over-the-counter. But they don't have the same effects as these opioids. So that's a different class. We'll talk about that a little bit as an alternative maybe, but when we talk about the opioids, we're talking about the ones above. Now, another thing we're not going to be talking much about, unless you have particular questions, are the benzodiazepine medications. And these include, you see, Xanax, Valium, Ativan, Klonopin. They're used as sedatives, anti-anxiety medications. They are very commonly used nowadays. They are impairing no matter what the situation. If people take one, they're impaired at work. If they're on them on a chronic basis, they're impaired at work. So these are medications you don't want your workers on if they're in a safety-sensitive position. The benzodiazepines are very much like the opioids as far as the prescriptions go, in that there's no indication for long-term use. All right, they're supposed to be used for very short term only, and then people are supposed to get off of them, but that's not the way it works. Doctors get people on them and then have a hard time getting them off, and people stay on them forever. So the reason I'm here and the reason I have this job is because the past 20 years, medications have skyrocketed. 20 years ago, for those of you that are old enough to have been in this business 20 years ago, this wasn't a problem in business and industry, and it wasn't a problem for medicine either. And the other issue is that these are impairing. All right, there will be people on chronic opioids sometimes for chronic pain treatment, and there's some question as to whether they're impairing or not, but in general they probably are. It's hard to say for sure if somebody is impaired or not. Sometimes it means being on these medications might decrease the reflex time by 1/10 of a second. You know, something that's hard to measure if a doctor's looking at them and trying to make a judgment, but something if they're in a safety-sensitive position where they have to react quickly that might cause a safety issue. So in 1997, this problem really started in the mid to late 1990s. And at that time, these medications were prescribed at a rate where if you average it out for every person in the country, it averaged out to 96 milligrams per person. All right, so most pills are between 5 and 10 milligrams, so we're talking 10 to 15 pills per person per year. So in 2007, 11 years later, that has gone up to 700 milligrams per person. And it's even higher now than it was then. And that's enough for someone to take a Percocet or a Vicodin around the clock for over a month. So that's the average amount. So obviously, we've greatly escalated our prescribing of these. We comprise 4%. We consume 80% of the world's opioids. So it's, I would say, uniquely American, but Canada's having a similar issue. They just don't have the population that we do. But between our two countries, this is a problem we have. My wife recently she's a substance abuse counselor and a mental health professional, and she was asked to do some speaking in some African countries regarding their substance abuse problem. And so she asked me about this, how much of these opioids are over there, and we looked it up. Almost none. There's none over there. It's all alcohol in those other countries. Because all of them come here, they can't afford the medications because we're paying so much money for them. We also consume 99% of the world's hydrocodone. And this is a graph from the CDC. And it looks at how the opioid sales, which is the green line, have increased, and it starts with 1999. It actually started a little before then. And it goes up to 2010. Since then, it has continued to go up. And it shows how correlated to that is the number of opioid overdose deaths that they've gone up, and the number of people that are being admitted to treatment. You know, and again, my job in addictions treatment, 15, 20 years ago, we just didn't have that many admissions. But nowadays, you know, it's all we can do to get people in. Everybody has waiting lists. You know, have more business than we can. And this get my job at the National Safety Council. This is the number of people. And it's now become so prevalent that there are more people dying from overdose than die in motor vehicle accidents. It's one of the leading causes of death. It is the leading cause of unintentional death in the United States. And looking at it compared to other diseases, now these are figures from a few years ago actually, but compared to breast cancer, we have about 39,000 people die every year from breast cancer. In prostate cancer, we have about 29,000 people die every year. From homicide, we're talking about 16 or 17,000. But from overdose, we're up, and that number is actually now above 40,000. It's up at 41,000. So the death rate from this is comparable to other major illnesses that we spend a lot of money and we spend a lot of time on. Let me share with you part of the reason this is happening. You know, again, I was in primary care, I still am, but back in the 1990s, there were several organizations that came out and said we need to do a better job treating pain. One was the American Medical Association actually had a group that looked at how we treat pain and came out with the conclusion we're not doing well enough. The Joint Commission on Accreditation of Hospitals said we're not treating pain well enough in the hospitals. They're the ones who really came out with pain as the fifth vital sign, so whenever you're in the hospital, they're asking you about your pain levels. And they really increased our awareness of treating pain. At about that same time, Purdue Pharmaceuticals came out with OxyContin. And they sold it to us doctors saying, here's a medication that because of its slow onset and slow action is not addicting, it's very safe, you can give whatever dose you need to get rid of the pain. If you give them 10 milligrams twice a day and it helps them, that's fine. If it doesn't, you go up to 20. If that doesn't work, you go up to 40. If that doesn't work, you go up to 80. And as long as they're having pain, they won't get addicted to it. It's very safe. So it kind of gave us this impression that these medications are extremely safe. They are the answer to pain. And doctors jumped all over that, you know. I mean, we want to make our patients feel better. And we started prescribing them, not just the OxyContin, but the ones that are similar to that. And they came out with more and more medications. So there's some unique characteristics of the opioids. And you guys that are dealing with your folks need to understand some of this. First of all, surprisingly, the pain relief from the opioid medications is minimal. They relieve pain about 10 to 15% is all. So actually, even the studies on OxyContin that were done, for a medication to be approved by the FDA to be a pain reliever, all they have to do is show that they're better than placebo. So they don't have to show that they're better than ibuprofen or anything else that's safer, just better than placebo. So, and they also don't have to do it for long term. Even though OxyContin is really prescribed for long-term pain, they just need to show that over the course of a few weeks it relieves pain. Well, it does appear to when people first start on it, but again, not a lot, 15 to 20%. But the longer they're on it, that pain relieving ability wears off some. So in the long term, there are no studies that confirm that these medications relieve pain in the long term. You know, 3 months or less, they have minimal effectiveness. Longer than that, maybe not. So they don't work very well. And actually, we released a white paper recently showing the evidence that shows that taking one ibuprofen and one Tylenol together, over-the-counter strength, is stronger than taking 2 Percocet pills together for relief of pain. So, you know, there is a viable alternative for pain relief other than these opioid medications. Now, the other thing about these is the mental health effects. Now, that's really how they work, is these work in your brain. So the non-steroidal drugs like ibuprofen, they work at the site of the pain by reducing inflammation and reducing some of the pain relieving issues there. So they actually work at the site of the pain. These medications don't. They work in your brain. And they work in a way that makes it so that it doesn't reduce the pain as much as it makes it so you're not that concerned about it anymore. Now, I don't have the, oftentimes when I talk, I give the definition of pain. Almost all medical organizations agree that the definition of pain is both a physical and an emotional response to something that's occurring in your body. And we think of the physical part, but we don't think that much about the emotional part. Well, these address the emotional part of that. So they make it so that you're not distracted. And you've probably heard people say that before. The pain pills don't take away the pain, but they make it so I don't care that much about it anymore. And that's really true. That's the way they work. Now, here's the other thing that's really interesting. These are very powerful antidepressants and anti-anxiety medications. So there have been some studies on people that have been in a psychiatric hospital, been on multiple medications, have had a convulsive therapy where they do the shock therapy and all this kind of stuff, and they're still very depressed. And they can give them some of these opioids, morphine in particular, and within minutes they're getting better. So y'all, anybody of you that know anybody that's been depressed, or if you've been depressed and you've gone to your doctor for depression, they might give you an antidepressant medication like Prozac or something, and they'll tell you this is going to take 3 to 6 weeks before you see any effect. And then it might not be much. We might need to increase the dose if you're not seeing any effect. And sometimes even before you start to feel better, it can be a couple of months. Well, that's not the case with these medicines. Folks will take one of these pills for whatever reason. Say their doctor gives it to them for a sprained ankle. If they have pain or anxiety issues, they take these pills, and within minutes they're feeling better. All right, they don't feel high, they don't feel goofy, they don't feel impaired. They just know their depression is better. They feel better. So these are high-risk medications with anybody with mental illness. It's because they just have that they feel normal again, sometimes for the first time in a long time. The problem is that effect doesn't last. All right, their body gets used to that, it starts to wear off. Then they have to take a higher dose to get that effect, and that's how many people get addicted, because they start taking more than their doctor prescribed. They're calling back early. He'll give them more for a while, but then he cuts them off when he thinks they shouldn't be getting them. They start buying them on the street, and the problem just escalates. So they come from the poppy plant. It's been around for thousands of years. There's evidence that they were using these 2,000 to 3,000 years before Christ, back in Sumerian era, and they used them both to treat pain and to treat mental illness issues. And so here's what happens. There's the poppy plant with the leaves. They are very pretty poppies, and actually, you can buy them for your garden. Now, it's not legal to sell the seeds that actually produce ones that are powerful with the opium in them, but they will have a little bit of the opium compound in it, actually. But there's a certain type that is grown mostly overseas, Afghanistan. They grow a lot of these. And they are very pretty. After the leaves fall off, you're left with this seed pod, like that. And what they do then is they get a sharp knife and they cut down the side of the seed pod, and this latex-like material comes out, and that's the opium. All right, so historically what they did is they collected all that and they dried it. Now, the opium contains morphine and codeine primarily. There's another one called thebaine, which we don't use very much. But mostly it's morphine. It's like 60% morphine, 30% codeine, and then the thebaine. All the other medicines like hydrocodone and oxycodone are derivatives of that. We make those chemically by changing that some. The first real derivative was heroin that they made from this. It's easy to change morphine into heroin, and that was done back 1800s, and it was done because it makes it much more concentrated and stronger. And back then they were shipping a lot of this stuff by boat, and so it made it so that it was more economically feasible to ship more of the chemical by changing it to heroin. So again, The Wizard of Oz. Has everybody seen The Wizard of Oz? Sometimes I talk to young crowds, they haven't seen that. So you remember the story. They're going to Oz, and the Wicked Witch is trying to do something to slow them down, and she says, poppies, poppies, and she makes these poppies. And so this is a great analogy for what my people that are addicted have experienced, all right? Life is stressful, there's a lot going on, they're having all this adversity, whatever's happening in their life, you wouldn't consider it just a calm and relaxed life. They've been through the jungle of Oz. And they take one of these pills, and it's like they're coming out in this beautiful poppy field. Again, they feel energized. So as you remember, Dorothy and those guys start skipping and running. They have energy. They feel alert. Everything is great. They're on top of the world. That's just what my patients feel like. And then as they go on, what happens? They start to slow down because they start to get these effects, and it starts to kind of build up in their system, and they slow down, and finally they fall asleep. And it's actually interesting, if you'll notice, that the two that fall asleep is Dorothy and the Cowardly Lion, because the Tin Man and the Scarecrow are artificial beings. They're not real beings, but the other two that have DNA are the ones who fall asleep. So how does Glenda the Good Witch reverse that? Do you remember? Snow. All right. So the analogy for that, this was written back at like the turn of the previous century, early 1900s. The analogy to that was snow was the nickname for cocaine. So that's very commonly what happened was people would take these and they'd get drowsy, and kind of get their buzz and be tripping on that. And then they'd come out of it if they had to go to work or do whatever by using cocaine. So snow was the antidote for the opium. So as you guys know, this is becoming more of a problem here. Dane County, 7 people died in 1995. In 2011, 83 died. So all of that comes because of the increased prescribing by the physicians. All right, without that, if physicians were prescribing much lower numbers, you wouldn't be having all these people that are dying. Now, I'm going to go forward, and we'll come back to this. The CDC has shown that the deaths, we measure the deaths, and that's easy to measure. But what they say is the tip of the iceberg. For every one person that dies, 15 people are admitted for treatment. There are 26 emergency department visits. There are 115 people who abuse them or are dependent on them. And there's 733 that take them for non-medical reasons. And, again, use that to get energy, to be calmed down, whatever it is. Again, I will tell you, the impression that many people have that folks are shooting these up to get high is seldom the case. There are some people that do that, but more often they're treating their mental health issues. And $4 million in health-related costs, which is significant, obviously. So if you work that out for Dane County, you have about 10,000 people in your county that are addicted. And now people that are addicted are, they're lying to get their medications, they're stealing from folks, they're doing whatever they can to get these pills when they shouldn't be on them, obviously. And you probably have up to 16,000 people who are taking them non-medically but are not yet addicted. So there's a lot of folks. You guys are having many of them work at your facility. So the impact on you guys, studies recently have shown that up to 23% of employees have taken one of these for non-medical reasons in the past year. So your folks are doing them. All right. The working age adults are obviously the main population that we're worried about. 12% of the population will receive a prescription for an opioid medication each year. So a lot of your folks are getting these, legitimately from doctors or for however they're getting it. But a lot of folks are getting them, and again, they will affect safety at your work. So as I mentioned, they are impairing. They shouldn't be taken at work. They cost you guys a lot of money. I'll go back to that. Studies years ago estimated that the cost to the American society was about $55 billion per year because of the opioid misuse problem. About half of that was cost to employers through lost time, sick time, whatever. You guys are bearing the brunt for a lot of this. Of the other half, the other $25 billion, some of it was medical costs, some of it was law enforcement costs. But it's you guys, the employers, that are bearing the brunt of a lot of this. So employees that take these medications are more likely to not show up for work, or when they do, oftentimes be late for work. They are less productive at work, all right? We call that presenteeism. So they're there, but they're not really getting a lot done. They're more likely to be responsible for a workplace incident, and they file more workers' compensation claims. So they'll cost you more money. They, partially because they're more susceptible to injury. Partially because one of the funny things about opioids is they actually make you more sensitive to pain after you've been on them for a while. So a minor injury can feel like a more major injury and can result in a claim as well. So looking at other effects, we talked about how they're not very effective for pain relief. But when taken after an injury, they do increase medical costs. So and a lot of these studies are actually workers' compensation costs, where they have people with, in particular, back injuries, but other injuries as well. And they show that if you receive an opioid after the injury for pain relief, you're more likely to have higher medical costs, and that's significantly higher costs. It increases your risk of disability. A prescription for an opioid medication like Vicodin or Percocet for a back injury that occurred at work, if you receive a prescription within 6 weeks of that injury, it doubles your risk of permanent disability. All other things considered equal. And that's, again, because these medications, historically, doctors have felt that if we can take away the pain, you'll be able to rehab better and you'll get back to work. Well, that's not the case with these because, first of all, it doesn't relieve the pain. It just makes them so they don't care so much about it. But also, they don't care about their rehab so much, so they're not getting up and doing things. They're not as active, and it takes them longer to get back to work. It increases the risk of disability. I think that's one of the main reasons they shouldn't be used, actually, because of all the disability we're having these days. Doctors give them out for everything, so almost everybody has these at their home, which is a whole different problem. So they're all around, but you don't want your employees taking them. And I promise you, your employees have them in their closets as well. They get up in the morning, they get a little bit of headache or something before they come to work, they're going to take one. They get injured playing football with their kid in the backyard. They hurt their back, they're going to take it before they come to work. They might see their doctor might prescribe it to them, but you don't want them on it at work, and we're going to talk about that in a little bit. People tend not to call back as much when they're on these, and again, it's because they don't care so much. So, they're still hurting a couple days later. If they're worried or anxious about the pain, then they might call back and ask something. But if they're taking these medications, they're still kind of mellow, and they'll delay their call for a few more days maybe. So it might be that we don't get as many callbacks, although that's never really been studied, I don't think. Part of it is doctors really believe that they're stronger pain medications and they need to be used. So that's part of what we're doing at National Safety Council, actually, is educating doctors that that's not the case. We're doing that two ways. We're working with the American Academy of Family Physicians and the American College of Physicians, who are the internist doctors, to develop practice guidelines on how to prescribe for acute pain to make it very clear to them that, again, even the over-the-counter ibuprofen and Tylenol is better than Percocet is. Kidney stones are considered some of the worst pain that there is. And even studying for kidney stones, they've shown that the NSAID medications like ibuprofen work better than morphine for pain relief for kidney stones. Doctors, they just don't know that. So how many of you actually have like a drug-free workplace policy? Good, so most of you do. Historically, these came out back in the 70s, and they were used as a law enforcement tool. So law enforcement came out with this as a part of the war on drugs. And it was meant to identify people that are abusing drugs. So what we try to say and what we try to demonstrate in our toolkit here is that it can also be used as a safety tool. So it needs to be expanded some to do that, though. But it can be very effective, I think. So part of what it does, it talks about the employee's role in workplace safety. And one of the things it says is that they need to understand if they work in a safety-sensitive position, they must tell you if they are given any medications that may cause drowsiness. So in particular, we're talking about the opioid medications and the benzodiazepines. You want to make it their responsibility to tell you if they're taking those, if they're in a safety-sensitive position, because it's going to impair them. It's going to be a safety issue. But it also really includes, there's over-the-counter medications like Benadryl can do that. And you don't want somebody driving out on the interstate probably after they took a Benadryl. A lot of positions, they need to have fast reflexes, be alert, and Benadryl will affect that. So there's a number of other ones. So what we often say is if it says on the bottle may cause drowsiness, they need to tell you about that. But we recommend that you specifically say the opioids and the benzodiazepines so they know that if their doctor gives them that prescription. Because some doctors won't know. They'll just give them a prescription and they'll say, well, can I work on this? And they'll say, oh, yeah, that's fine. But it's really not. So it needs to say in the policy that if they're given those, they need to tell you guys about it. And here's the big thing we talk about is reviewing your drug testing panel. So how many of you just test for those 5 drugs? Anybody in here just doing those? There's one. So actually, as a very large number of companies, probably the majority if you look at panels that get the SAMHSA 5 test. And that's what a lot of the drug testing companies push. And this is what SAMHSA is, the Substance Abuse Mental Health Services Administration. And this is what they came out, again, with at the beginning of the drug-free workplace programs to address legal issues. Now, they didn't want people smoking marijuana. The opiates test does not test for all opiates. It in particular was designed to test for heroin. So we'll also pick up morphine, which is in the opium that we saw at the beginning, and the codeine. So those are the 3 main things it'll pick up. It won't pick up oxycodone. It does pick up hydrocodone, actually. There's kind of a cross reaction there. But it won't pick up the oxycodone. It won't pick up methadone. It won't pick up a number of them. It won't pick up Dilaudid. Cocaine, obviously, was a problem. Amphetamines, and PCP. So if you do this test, you're checking for the illegal things. But you're missing, again, a number of the opioids. You notice the benzodiazepines aren't on there. So anybody taking a benzodiazepine is going to have a negative test. So that's another issue. So we recommend that you talk to your company, and you need to talk to your drug company, testing company, and make sure that they're including oxycodone. That is the most commonly abused drug nowadays. So make sure you're testing for that, because it won't be positive on the regular opiates test. You should be testing for methadone probably. And again, a lot of doctors are using that for pain, but it's also a treatment medication. There's a lot of controversy about people in treatment, and again, I do methadone treatment for folks, so I've got a number of folks that are on chronic methadone. Is that safe in the workplace or not? So people that are getting a CDL, the DOT says that you can't be on methadone and get a CDL. You can't do that and drive. But many other workplaces, there's some controversy, and my patients ask me about that sometimes, if I'm on this methadone, will I be able to keep working? And it's kind of a difficult issue, but you ought to know about it anyway if they're taking it. And to be honest with you, my recommendation is if it's a safety-sensitive position, they probably shouldn't be on methadone. Now, methadone might be necessary for the treatment, so if possible, you might need to find them another position where that's not a safety-sensitive position. Benzodiazepines definitely should be tested for. Consider also fentanyl. Fentanyl, it doesn't come in an oral form. It's most commonly a patch. It's also injectable. People are starting to abuse that now. That's getting to be a big thing that people are overdosing on and abusing. It's oftentimes mixed with heroin nowadays, actually. But it's very dangerous. If people are using that, they got a problem. Tramadol is Ultram. A lot of controversy regarding that. When it first came out, they said it was not addicting. It's an opioid-like medication, but not addicting. Now we know that it is addicting. It is impairing. Many companies are testing for this. It's probably minimally impairing, so it's not a real big deal, but oftentimes it can be a gateway medication also. I don't like it as a drug to treat pain. It also has the same mental health effects, so it works actually very similar to Prozac for depression and anxiety. So a lot of people that start on it for pain end up taking it for their depression and anxiety. But they get to use it chronically. They do start to develop some tolerance to it. So it's a medication you want to know about probably if it's used a lot in your area. One of the things that is probably helpful is to call some of the substance abuse treatment programs in your area. Say, what drugs are you seeing? This is what we're doing on our panel. Will this pick up the drugs that you guys are seeing in your program? And if they're saying, gosh, we're seeing a lot of fentanyl lately, you might want to add that to your panel. But K2 and Spice, they're doing all kinds of variations on those for these synthetic drugs that people are using. It's hard to pick those up. Some of them are not even illegal because there's such a fine definition of what's legal and illegal. And those and the synthetic THC products now that they're coming out with. So there's just all kinds of other things that are going to be probably more of a problem the next few years as time goes on, as we start to address this even more. But yeah, you can get pretty extensive panels, but you're going to pay a lot of money for those, obviously, if you're doing that. So you kind of have to find that balancing point of what's cost effective for you and what can help your employees. How many of you are working with medical review officers, reviewing your test results and stuff? So the whole medical review officer industry is kind of an interesting thing. They all work differently. They have different areas of expertise and comfort levels. But the medical review officer, the history for them is they came about during when the drug-free workplace programs first developed to help see if you had a positive test, was it related to a legitimate prescription or a legitimate use compared to illegal use. So again, their history goes back to whether it's legal or illegal, not whether it's a safety issue or not. So we're trying to encourage you to work with your MROs, talk with them, develop that relationship with them to let them know that you want to use this process as a safety issue. Because right now, many MROs, they get a positive oxycodone result. They'll talk to the employee will say, oh, I got this prescription, and they'll call it a negative result because it wasn't illegal. But it still might be a safety. You guys just see it as a negative result. So I'll give you an example of a patient I admitted to treatment just a month ago. This guy came in to see me. He says he's doing 400 milligrams of oxycodone IV every day. All right, so that oxycodone is about about $1 per milligram. So he's spending $400 per day. And he's been doing this for years. Now he works at this big paper mill on a paper machine that is a very high-risk job. And I happen to know the mill and the testing they do, and they do test for oxycodone. So I said, how have you been getting by with a positive oxycodone test when you get tested? He said, once a month I go to urgent care, I tell them my back is hurting me and the only thing that works is Percocet. I get a prescription for Percocet. When my drug test comes back positive, I just need to show that to the MRO. Say, I got this a few weeks ago, I'm still taking it intermittently, and he calls it a negative test. And so for years, he'd been working impaired at work with the MRO signing off on it. So you need to talk to your MROs and let them know, if we get a positive test, if it's a safety-sensitive position, we need to talk about, this, and we need to know it's a positive result, and you need to work with them. No, we are so far behind in testing for drugs compared to alcohol, and there's just all kinds of different rules. So no, there's not a particular level that can be impairing for one person or not for another. And theoretically, some of the studies have showed if you're on a stable dose of an opioid and you've been on it for more than a few weeks, it may not be impairing even a high dose like 400 milligrams of oxycodone. Now, this guy was injecting it, so clearly after he injected, he had higher levels and it was an issue. But people that are taking them orally, stable levels, even though they have a high level in their bloodstream, they're not impaired if their body has developed that tolerance to it. So you don't really develop such tolerance to alcohol, so we can get more of a direct one-to-one relationship as far as level of impairment compared to alcohol levels, but that's not the case with drugs. So in our workplace policy toolkit, we talk about documentation. In particular, your policy, you need to document a lot of things up front so people know what to expect. They know what you're going to do if you get a positive drug test, how you're going to handle it. It needs to be handled pretty consistently, and there's several different possibilities. The positive test with no explanation, the person tests positive for oxycodone because they're buying it in the street and they don't have a prescription, that's pretty straightforward. But how about the person with a legitimate prescription? What are you going to do with that? What conditions must be met before an employee can return to work? Do they have to be completely off the pills? Do they have to be on a stable dose? Are you going to have them see somebody for a kind of a fitness for duty evaluation? The problem with those, and we don't address the fitness for duty issue much in our toolkit because we're not real sure what to say about that. Because, you can go to your personal doctor, and I've had people come to me in the past about this, say, I'm on a stable dose, my employer wants you to say that it's safe to work. And they drove in to see me and they look okay just looking at them. But we can't really do the assessment that needs to be done. Again, they might have a 1/10 of a second slowing of their reaction time. You can't judge that in the medical office. Your occupational health doctor can't judge that. So is it really safe? Are they really fit to return to duty? It's really kind of a gray area, and we don't know what to say about that. So, maybe one of the best policies is just as long as you're taking these medications, you can't work in your safety-sensitive position, we'll find an alternative job for you. And that might be sorting out bolts and nuts and, somewhere that is extremely boring, but it's safe for you anyway. Our toolkit talks about training supervisory staff. All right, there's a number of things they need to know. They need to understand the problem with opioids and why these shouldn't be taken to work. So they need to be trained like you guys are on the overall problem. They need to know the signs of an employee that might be taking these, that might be developing a problem. They need to know how to approach that employee if they do understand, if they are suspicious of that. And basically, we're saying it should be something you approach the employee out of concern for them and their safety. This is not an accusatory thing. You just say, I'm concerned there may be a safety risk. We need to do a drug test just to make sure everything's okay. And if it is, that's fine. But if not, then we'll address that if it comes up. So most supervisors are extremely uncomfortable with this. So training has to be a really important part of it. And, a lot of the signs are subtle. Maybe they just notice they're not working as well as they had in the past, or, they seem to be not communicating as well, or they're coming in late periodically, or there's some stress. And, it could be other things. Stress at home affects work performance as well. So, oftentimes they might request a test and it might be negative. They need to know that's okay. A lot of them feel they have to be 100% positive and the test has to be positive, but no. You got to figure there's going to be a number of negative tests for people you test if you're really screening these folks well and getting them in. So we talk a little bit about that, about signs they should look for, and sheets. We have sheets you can give them to talk to them about that, to train them. You guys have supervisors that get this training or that feel comfortable doing kind of the reasonable cause testing? Most places don't. You guys do? Most places don't, and supervisors just are not. That's a real weakness for a lot of policies. Supervisors, they maybe even see these folks and they have a pretty strong feeling that something's going on. You work with people for a long time, you can tell when something's different, but they're afraid to approach them and they don't really know what to do about it. And their company doesn't enforce that or doesn't, recommend that. And that's what, you just need to learn to frame it and get your employees to understand that needs to be part of their education as well. Say, if we have any concerns about you, this is just part of what we're doing out of our concern for your safety. And we expect there to be some negative tests. Don't take it personally. If there's a positive test, we'll address that as well. We just want to keep you safe and keep your fellow workers safe also. Oftentimes it's an issue for those working around them. So let's go back to the testing a little bit. When should testing occur? These are the times we recommend: pre-employment to identify problems, post-incident to make sure drugs were not involved in whatever it was, reasonable suspicion, and random testing for those who work in safety-sensitive positions. That random testing doesn't need to be done on everybody specifically, but those that are in safety-sensitive positions, they should be. And again, partially that's a disincentive to use the drugs, but also you want to make sure and catch anybody if they are using them before they have an incident. So you're talking about what kind of testing we should do. Urine is still the gold standard. The testing part of it is actually very reliable. It does concentrate the drugs, so they're more detectable in the urine than they are in some other places. The issue is that there are multiple ways to try to work around that system. From adulterating the urine to taking a diuretic to make the urine real thin, to taking other medications that change the pH in the urine so things aren't measured as easily. Even stories of people that catheterize themselves beforehand and put someone else's urine in there. So it obviously should be observed. It should be a place that's used to doing it. But when it's done correctly, it's kind of the gold standard. The oral fluids is, as he said, much more convenient at places. These little things people can they put them in their cheek and it collects a little bit of saliva. It's hard to cheat those. You don't have to have a bathroom to do it. It's pretty good. The drawback with the oral fluids is that, again, the drugs are not concentrated in the oral fluid. In fact, in particular, benzodiazepines are at much lower levels. They're about 1% of what they are in the bloodstream. So, you have to have a pretty high level in your system before the benzo test is going to be positive on an oral test. So you just got to figure you're going to miss those on the oral test. Now, they're working to make that better, but pretty much you ask your drug testing company, if they tell you they're doing oral testing for the benzodiazepines, they're using the same cutoff limits that they have for the urine, and you're just not going to find those in oral fluid no matter what kind of doses they're taking. So hair testing is another option. That one is also, extremely hard to cheat. They cut it close to the scalp and they take about 1 centimeter and it measures the last couple months of drug use. Benzodiazepines also do not show up very well in the hair test right now. So that's one that you're going to miss if that's the case. But there are a number of companies that are doing the hair testing. And some companies will do a combination of those. They'll do the urine test when it's convenient and available, and they'll do the hair testing at the time. A number of trucking companies now are doing hair testing to kind of see what people are doing. So, the hair testing looks at any use. So if they're doing something when they're on vacation, it might not affect their driving, but they have in their policy you can't use it and you can't have a positive test. And as long as the policy states that ahead of time, they know that. So it is also an option. They are getting a lot better at the oral fluids and the hair testing than they were just a few years ago. So, expect to see some other things. We don't see many companies doing the serum testing, actually. Have any of you used that? Blood testing? It's just not convenient. It's more expensive. We don't know what to do with the levels anyway. So we don't see many folks doing that. So what do you do if you get a positive test? You've got several options. Again, this needs to be defined in your drug-free workplace policy that people know ahead of time. You can continue employment and work on getting them into treatment or having evaluation. You can terminate employment at that point with a chance to rehire to come back to work, once the whole situation is taken care of. Or you can terminate employment without rehire. Say, positive drug test and you're out. Now, there's advantages to all of those. I will say continuing employment and getting people into treatment, I think that's one of the ideals. Again, I do a lot of treatment. I see people very successfully treated when it's done through the workplace. I've got some folks that are just wonderful employees now, undoubtedly, once they got into treatment because they've got a whole new life and things are better. And even terminating employment with a chance for rehire is okay as long as you really give them a chance and you're not mad at them. Terminating employment without rehire has been shown to be a strong disincentive for people to using drugs. And you know, they do kind of learn a lesson from that. You know, they lost their job, they're not getting it back, now they have to find another job. The next time they might think twice about using drugs. So there is some advantage to that as well. But those are all possibilities. Again, it should be explained in your policy. If you're going to continue employment, you need to take advantage of your EAP. First, they need an evaluation by a substance abuse professional to identify whether this is a problem, you know, whether they are taking them as prescribed, whether they're abusing them, or whether they're actually addicted to them. The difference between abuse and addiction is abuse, you're taking them just when you're not supposed to. Addiction, you actually have to have them, you're craving them, you know, you're doing all kinds of things to get them. It's a more significant problem. But that kind of level of involvement needs to be identified. That can be done by a substance abuse counselor. Normally that's done through your EAP program. You need to talk with your EAP programs, make sure they're comfortable doing this, make sure they have a qualified substance abuse counselor to do the evaluation. You know, some EAPs are better than others. You know, most of you contract with larger companies or with just local folks? Okay. Anybody just with like a local group? In particular, the larger companies, you can pretty much count on them doing well. But the local groups, you need to make sure that they are comfortable with substance abuse evaluation. You know, they might not do treatment there. They might refer them for places for treatment. But you need to make sure they have those resources and they can work with you on that. So again, you need to be talking with them, see what they can do. And as we mentioned here, employees that are referred for treatment by their workplace have a high rate of success for treatment. Again, I see that where I work, that people are very motivated to keep their job, and you know, usually they're upset that they upset their employers because they had a positive test. You know, they want to prove to them that they're good people, that they can get back to work, and it's pretty cool to see them referred and get back on their feet again. So talking about treatment options for people that are addicted. So there's really just a few options. One is detox only, and that's where, you know, people that withdraw from opioids, it takes 2 to 3 weeks to get through the physical symptoms, and the physical symptoms are horrible. Right? They feel like they have the flu. They have shakes, chills, sweats, they're vomiting, they have diarrhea, they ache all over. You know, it's like the worst case of flu you can get, and people have a very hard time going through it on their own. So most of my folks that come into treatment have tried it. They realize they have a problem, and they've tried it on their own, and they make it about 2 days is all. And you know, it's going to last 3 weeks, and they make it 2 days, and they can't stand it anymore, so they get back on their drugs again. So detox is difficult. Now, it can be done in an inpatient unit where they give them other medications to help with that. Clonidine is a blood pressure medication, which actually helps relieve the symptoms a little bit. So there's a number of things they can do to make it a little easier, but it's still a difficult process. But it's done in a controlled environment where they can't get back to their drugs. So that's a possibility. You can also detox either with methadone or with Suboxone, and we'll talk about those in a minute, where you put them on these medications, and it makes it a little easier to detox off, but you still end up going through withdrawal. It takes a little longer. But the goal for detox is that when you're done, they're not taking any of the opioid medications. Now, the drawback to that is addiction to opioids is a disease. It's a chemical problem in the brain. Many of these people got started on these because when they first took that first dose, it made them feel energetic. It gave them confidence. It affected them differently. But after they've taken it for a while, it really affects the chemical levels in your brain. Like the serotonin levels go down. The norepinephrine levels go down. This has been measured. Dopamine levels go down. Dopamine is the key chemical in our brain that makes us feel good, that makes us happy. So, for instance, you're at work and your boss tells you, boy, good job, you really did good on this, and you're feeling good about yourself. That's the dopamine that's surging. You know, you are watching a ball game and you know, the Green Bay Packers win big over the Eagles or something, and you're feeling good. That's the dopamine that's going. And really, you know, you eat a good meal. That's dopamine that makes you feel good about that. Dopamine is that main chemical that makes you feel good. And the opioids make your dopamine levels go up initially, but then they come down, and then as you come off it, they get below normal. So you're just feeling rotten. You know, even though you've gone through the detox, you're through the physical stuff, you're just feeling low, you're depressed, you tend to have anxiety, you actually crave these medications, and it's because of these chemical changes, many of which are permanent in your brain. So these people feel lousy even after they get through the physical detox. So while detox is an option, it has a very high failure rate. People that go through detox within 6 months, 90% of them are using again. And even long-term after that, when you look 3, 4, 5 years down the road, they still are at risk of using again because their brain never gets back to normal. You know, they tend to have this depression and anxiety, and they know if they take one pill, it's going to fix that. And something happens, a doctor might prescribe it, you know, a friend gives it to them, whatever. They take that one pill, and it gets them back into their habit again. So again, I see this all the time. Detox is an option, but it's only for those that are very strongly committed to doing this. They have a very strong support system. They're going to get involved in AA. There are a number of mental health professionals and substance abuse professionals that think that should not even be offered as an option, though, because it has such a high failure rate. It actually has a high mortality rate. People go through detox, they start using again, they get back on their regular dose, and they overdose and die. So we see that for people coming out of jail. They go into jail, they are forced to detox in jail, and then they come out and they shoot up with something and they die right after they come out. So, you know, it's dangerous, it has a low success rate, but it is an option that should be talked about probably. Medication-assisted treatment is what I do. Methadone is historically the one that's been used. Methadone replaces those chemicals in the brain that are missing. The advantages of methadone is that it helps replace those, and when taken at a stable dose for a long time, it greatly reduces the risk that they're going to relapse and start using pills or heroin or whatever they're using again. It does make them more productive in society. They tend to get their jobs back. It's been shown to have a lot of social benefits to get people on methadone. The drawback to methadone is it may be impairing, which is why you can't get a CDL if you're on it. And we don't know what to do with that in the workplace. My patients that I treat, I recommend that they get in some position at work that is not safety sensitive, that they talk to their bosses about that. We cannot at a methadone clinic report to an organization that their client is seeing us. We can't even report to their doctor without their permission. But it's a good medication, and it's very successful in getting people off these pills. It can be used long term. It can be used the rest of their life. One of the advantages of methadone is once you reach that dose that is a stable dose where you're not craving and where you're not having any withdrawal symptoms, you know, you're just feeling normal, you can stay at that dose. You know, all the other opioids, you develop a tolerance and you have to go higher and higher. That's not the case with methadone. You find that dose and you can stay on it for years and years and years oftentimes. So many people will be on it their whole life. We tell people when they come in, we're going to start you on this medication. I don't know how long you're going to have to take it. You might have to take it the rest of your life. You might be able to come off it in the future if your life gets better, but don't think about stopping it now, all right? We're going to get your life, you know, some semblance of a reasonable life, and we'll talk about that later when you want to. Buprenorphine or Suboxone is another option for medication-assisted treatment. It is like methadone in that it's an opioid-like medication. It's also like it in that you reach a steady dose and you don't have to take a higher dose in the future. You can just stay on that same dose forever. It is actually much safer than methadone. It's almost impossible to overdose on the buprenorphine. Methadone, it's easy to overdose. There's a lot of drug interactions. There's a lot of heart effects. You don't get those with the Suboxone or buprenorphine. Drawback is it may not be quite as effective as the methadone, but it's pretty close. Buprenorphine can be prescribed by doctor's offices. People can get a prescription, go get it, you know, come into their doctor every month or so and get a checkup. Methadone has to be dispensed at methadone clinics where people come in every day to get it. And again, it's because it's more dangerous. Suboxone is not nearly as impairing as the methadone is, and it might be safe to use that in a safety-sensitive position. So it is a drug that's available in the street sometimes. The impression from most people that are in the treatment area is that it's not so much abused as it is taken by people who want to. They can't get their own drug, they're going through withdrawal, prevents their withdrawal, so they take it to prevent withdrawal until they can get their drug again. Or they're trying to treat themselves and get off their drug, whatever they're using. So we see a lot of folks that come into treatment for Suboxone, and I also do that put it on the street, realize it's a good drug, they feel normal on it, and they want to change it and take it in a treatment program, and they come in to see us. So that's an option. It's probably a better option for most people. It's not as controlled as the methadone, but the methadone for people that are doing heroin in some high doses, methadone might be better for them. So lastly is naltrexone or Vivitrol, and it's an injection that's given once a month. Now, it's different from these other ones in that it's not an opioid. In fact, it blocks the effect of opioids. So you give people an injection that lasts for a month, and if they take a pill or inject heroin or whatever, it'll block the effect of that. They won't feel anything. So the disadvantage is it doesn't help with the chemical changes in the brain as much. So these folks will tend to have more craving, will tend to relapse more. Of the medication-assisted treatment, it is the least successful, but it is not impairing at all. It's completely safe to do. There's no side effects to it. So for certain people, that might be the drug of choice. And it's been shown for people that are in high-performing jobs, like airline pilots, like physicians and other medical professionals, that they are more successful with this medication. They need to be highly motivated, and oftentimes it's their job that makes them highly motivated. But people that are on this, they come in once a month, they see their doctor, they get their shot, they're in other treatment as well, hopefully, and they can work at any position at work. It's completely safe. It's not impairing at all. So that's one of the advantages of those. One of the drawbacks is it's extremely expensive, about $1,500 per shot, and you're getting it once a month. I think one of the key points here, and one of the things I really stress, is the disease model of addiction. That a lot of folks just say, and we hear it from our folks that are on the methadone and buprenorphine, you're just trading one addiction for another. Well, the disease model says that this disease occurs very much like diabetes does. The majority of people that have diabetes got it because they ate too much throughout their lifetime, they're overweight, and their chemicals in their body are not working the same. So their insulin doesn't have the same effect it used to. Their body is resistant to it, so their blood sugar levels go higher. Same thing with, it's similar to COPD. People smoke cigarettes, it causes damage to their lungs, they can't get the oxygen, and we need to treat that for various things. It's the same thing with these medications. They've taken the pills for so long, it's made chemical changes that occur. They need a medication to treat it. It's no different from those other things. If they come off of it, we don't punish people with diabetes if the sugar goes too high by throwing them in jail. But people with addiction, when they have a relapse, when they have a problem, they take some of their drugs, and we don't think too kindly on that. So medication-assisted treatment is often necessary. Again, I will tell you from a workplace safety issue, Suboxone is probably safe in the workplace, but you still might want to think about putting them in a non-safety sensitive position. Methadone, I would strongly probably recommend you put them in a non-safety. If you know that they're on methadone treatment, that they be in a position that's not safety sensitive. You can really work with your EAP, take advantage of them. They can do evaluations or recommendations. They can either do treatment or refer for treatment. They can keep you updated on your employees about how they're doing and when they think they can return to work. If they're getting into medication-assisted treatment, that might be 4 to 12 weeks before they can come back once they're on a stable dose and things are going well. If it's Vivitrol, it might be sooner. But they can keep you updated on what's going on. We do recommend random blood or drug tests after they come back to work on this particular problem. Again, that should be stated in your policy ahead of time that if you're out for a positive drug test and you come back after treatment, we can do random drug tests. And again, that acts as a disincentive to keep them from using again, so it's very helpful. So some EAPs will also do supervisor training. Again, that's a difficult part of all this, is getting supervisors to understand how to do their job and their role in all this. But some EAPs will do supervisor training. I think ours does, doesn't it, Tess? So take advantage of that if they do that. They're experts at that. That's a great resource for you. And EAPs are most effective if they're widely promoted to your employees. If they know they're available, if they're concerned that they're getting a problem, they can reference your EAP and get involved anonymously. They can call them up if they're having any other problems. It's actually been shown that depression itself can be a safety issue at work. People that are depressed are not as alert and not as responsive to things. So, make sure your employees know that they have an EAP program. They really tend to be underutilized in all organizations. They are a very valuable part of what you can do and how you can help your folks. So in our employer toolkit, we also talk about workers' comp issues. Now, I will again qualify what we're saying by saying that workers' comp laws are different in every state, and I'm not that familiar with Wisconsin's laws. Can you guys direct what physicians your employees go to when they're injured at work? You can't? They go on their own? That makes it a little more difficult. But there's important things that you need to know, and whatever doctors your employees are going to, you need to make sure they know as well if you can get this information to them. And that's it. Opioids after an injury will increase medical costs. They delay recovery. They increase the chance of disability. And they're no more effective than the over-the-counter pain medications. So in particular, if you got occupational health doctors, you need to make sure that you're working with them, that they're not prescribing many of these opioids at all. If they do, it's just for a day or two and not keeping people on them. But in fact, if they can avoid them altogether, that's the best option. And if you've got one back doctor in the area that is prescribing a lot of these medications, go to them as well. Again, look up our white paper online and take it to them and say, this is the evidence, and for our folks to come in, we know that you're increasing our cost by using these medications. We want you to start recommending the over-the-counter medications and treating them differently, and just go have a talk with them, you know. Set up a lunch or something and meet with them. You know, there's just all kinds of information on what these medications do for folks. For people with back injuries, it makes them more, if they're started on it, makes them more likely they're going to end up with surgery. You know, people with surgery tend to have worse outcomes. People that are on the pain pills before surgery have worse outcomes than people that are not on pain pills before surgery. So that's kind of the slippery slope. Once they get started on these pills, it gets to be a real problem. Another thing we talk about is your major medical insurance, because that also can be a player in this. Your folks that are injured when they're not at work and are going to see their doctors. If it's being filed on their insurance, there are some folks, many of these companies have pharmacy benefit managers that are kind of managing some of this, and we'll look at this. But you can talk with them ahead of time, and again, some of this is in our toolkit about what questions you should be asking them, you know, how you should be working with them to make sure that when your folks are getting prescriptions outside of the workplace and outside of any work-related issues, that they're not getting the opioids, or if they are, it's very short-term use and they're not getting on chronic doses or high dose or high levels of these medications. And again, a lot of the pharmacy benefit managers can work with you on that. So you know, just have a frank discussion with them, and you know, they can change some of their protocols, especially if your company's big enough. Say, you know, I want to make sure you're managing our folks that get prescription for opioids. You know, if they get it for more than 10 days, we want pre-approval. You know, talk to them about various options that can be done. Talk to them about how well they cover the non-opioid management of pain. So that's one of the things that we don't do much of in medicine. We're trying to do more of. You know, we talked about the medical incentives to prescribe these pills. One of the reasons is you can give them a prescription and get them out of your office. All right, if you're starting to talk to them about various exercises they should be doing, what kind of rehab they should be doing, making referrals to other rehab sources or chiropractors or whatever, it takes more time. So make sure doctors are reimbursed for that. Make sure that if you send them for physical therapy, it's going to be paid for, and not just 1 or 2 sessions, but you know, for however long it takes. You know, if they need to go to, I don't know if I have it. If they need to go to counseling or whatever it is to help them deal with the pain, make sure those are all options that are available. And you know, the insurance companies have really gotten away from paying for these other modalities over the past years. So they're partially to blame to all this also, because it is easier just to give pills than to try to do it for us. You know, we see this with the Medicaid and Medicare population as well as private insurance. But you guys, again, can have some incentive or you have some power working with your company. Say, you know, before we renew this contract, we want to make sure you're doing this, this, and this, and it's not going to cost our employees very much, and this will be accessible to them. Make sure that they also cover substance abuse treatment. You know, again, for someone who does that, this is a very important thing to me. In North Carolina, where I am, we're like you guys here in Wisconsin, where they didn't approve Medicaid expansion for the Affordable Care Act. The majority of people that get into treatment do not have insurance, and it's a financial burden for them. And oftentimes when they drop out, it's because of that. But your folks that are employed, that's a different situation. But make sure that your insurance covers that. You know, there's now supposed to be parity in the mental health services and physical services that are provided. But make sure you talk to your companies that they are providing mental health treatment and addictions treatment both for as long as necessary. There shouldn't be any time limit on it as well. Yeah, and you know, we're realizing that through all of medicine is that people with depression and with mental health issues do not do as well physically, whatever their issue is, you know, whether it's diabetes or high blood pressure or whatever. But in particular with pain-related things, again, because there's such an emotional component to it, you need to be treating the mental health things as well, and people are going to get back to work sooner. So other resources, again, we have posters in there that you guys can use. I encourage you to look at this. Employee education materials, supervisor education materials, safety talks that are just canned, so you can just pull them out and do them. You know, it's real easy. We have some resources from SAMHSA, again, the Substance Abuse Mental Health Services Administration, for education of employees about, you know, just back pain and injuries and the opioid medications and stuff like that. So that's all available on there. Well, again, we are a resource. Feel free to call me, or you know, we can talk with Tess and let us know if we can do anything. Get on our website. We encourage you to download that and look at it. Give us feedback if there's more stuff you could use from it. If there's, you know, any way we can change it or add to it, let us know, and we'll keep working on that. It's a work in progress, but we appreciate the chance to speak with you all today. So thank you.